So, chairpersons and ladies and gentlemen, good morning to all of you. I shall be discussing the role of the next generation basal insulins in overcoming hypoglycemia. What I'm showing here is not a timeline, it's an innovation line. It's been almost 100 years since insulin was discovered. And following the discovery of insulin, which was at that time short-acting, had high variability, highly impure, the first intermediate sort of insulin which was then prepared was Lente and then NPH. And the reason to do that was to prolong the duration of action so that you did have a longer duration of action, but it was not truly 24 hours. And NPH insulin suffered from the problems of high variability. And that is why basal insulins, which really worked for 24 hours, had a flatter action profile and hence had a significantly lower rate of hypoglycemia, especially nocturnal hypoglycemia were developed. And you had two of them to begin with. You had insulin glargine U100 and you had insulin detemir. Now, these two insulins were a significant development from the NPH. They reduced the rate of overall hypoglycemia by about 40 to 60%, and the rate of nocturnal hypoglycemia by about 40 to 50%. It was a significant development. But then the problem of variability was still there with the U100 glargine and the detemir. And in some patients, they really did not work for 24 hours. And that is why U300 glargine was developed. It does really work for beyond 24 hours. It has definitely a better record as far as glycemic, the variability is concerned, and as far as the risk of hypoglycemia is concerned. Obviously, the degree of advantage that you gain from an intermediate to a first generation basal, you don't get the same advantage from transiting from a first generation basal insulin to, say, a U300. But still, it was a significant advantage. And then now we have the ultra long-acting basal insulin analogs in the form of insulin degludec, which in fact has a duration of action of up to 42 hours and a very good low variability. Now, between the two, between U300 glargine and insulin degludec, there are contradictory reports as far as inter-day variability is concerned. But as far as intra-day variability is concerned, probably degludec seems to be better than the U300 glargine. So the basic idea of developing basal insulin analogs as opposed to the intermediate acting insulin was to have a truly 24 hours action with a flat action profile to reduce the variability and, of course, most importantly, to improve the risk of hypoglycemia. The basal insulins are not more efficacious. The third generation, for example, are not more efficacious as far as glycemic lowering is concerned. Where they score is the risk of hypoglycemia, so that's the whole aim. Now, let me just discuss the evidence. First, let me discuss the two newer basal insulins, that's U300 glargine versus U100 glargine, and then insulin degludec versus U100 glargine. And then I will then compare the two, that's the U300 glargine and the degludec. So the U300 glargine, if one were to discuss and compare it with the U100, when it underwent the clinical development program, it was studied both in type 2 diabetics as well as type 1 diabetes. And in type 2 diabetes, basically in two studies, the basal insulin which was being used in those patients was pretty high doses, so at least 42 units per day. In addition, one, you had a prior basal insulin plus a mealtime insulin, and in addition, two, you had prior basal plus oral therapies. And then addition three was in insulin-naive patients, okay? And then you had a study in Japanese patients who were on prior basal and oral therapies. And because these three studies had similar design and similar endpoints, you could pool them together into a sort of a meta-analysis. So this was the meta-analysis. And in type 1 patients, you had addition 4, which was prior basal with a mealtime insulin, and you had a Japanese study, again with prior basal and mealtime insulin. So this was the design of the addition program involving U300 glargine, which essentially was non-inferiority to U100 glargine. What they're trying to look at is non-inferiority to U100, and of course, secondary endpoints included hypoglycemia. So as I said, you could do a meta-analysis of those addition 1, 2, and 3, and the primary endpoint, of course, was the A1C reduction, and of course, because there was a treat to target, you're adjusting the dose based on the fasting plasma glucose. So as expected, and what they set to prove that U300 glargine is non-inferior to U100 glargine as far as A1C lowering is concerned with identical fasting plasma glucose. This is what they set to prove as the primary endpoint. How about the safety? There was one more point which was noticed, and that was regarding the insulin dose. So when you transition from a U100 glargine to a U300 glargine, you do require a slightly 10 to 12% higher dose, okay, of U300. You need a slightly higher dose of U300 glargine. Why does that happen? There are various postulates put forward, but one postulate is that, remember, U300 glargine is a more compact depot in the subcutaneous tissue. And when there is a more compact depot, it remains for a longer time in the subcutaneous tissue, and it is then has various interactions with tissue peptidases. And therefore, the bioavailability of U300 insulin glargine is slightly lower compared to the bioavailability of U100 glargine, which is you may require a 10 to 12% higher dose. This has been seen across trials, okay? Coming to the analysis for hypoglycemia, yes, as far as the U300 glargine is concerned, shown in green, whether it's anytime hypoglycemia or whether it's a nocturnal hypoglycemia, there is a significant lowering in the risk with U300 glargine. So certainly, safety seems to be better for U300 glargine compared to U100. Now, let me compare insulin degludec with U100 glargine, okay? Now, this is the DEVOTE study. The DEVOTE study was not a study primarily to investigate hypoglycemia. It was a study to establish CV safety of insulin degludec. Remember, in the ORIGIN trial with U100 glargine, the CV safety of U100 glargine was established. So that was one insulin you definitely had a CV safety, okay? So you're now comparing insulin degludec with U100 insulin glargine, which has proven CV safety. That was what the DEVOTE trial was all about. It was essentially a CV safety trial of the insulin degludec. So basically, all these patients were, of course, type 2 diabetics with at least one oral agent or insulin, but all of them had a high CV risk profile. So they could either be patients who were 60 years of age with at least one other cardiovascular risk factor, or they could be at least 50 years of age with a proven cardiovascular or a renal condition. And when you analyze these total patients of 7,000 odd, about 80% of them actually had an established CV condition or a renal condition or both. So remember, they are at a high CV risk profile, and their A1C was either above 7, or if they were on a current basal insulin dose of at least 20 or more units per day, their A1C could be below 7. Okay, so this is looking at time to the first CV event. Okay, so it's an event-driven trial. Okay, you're looking at so many primary events. This is what you're looking at. One arm has degludec with standard of care. The other arm has U100 glargine with standard of care. And remember, it did not, the primary endpoint was not hypoglycemia. This was the primary endpoint, the time to the first MACE, and it proved non-inferior. So you can therefore infer that insulin degludec is cardio-safe, okay? But there were two other endpoints which they also looked at secondarily. One was the nocturnal severe hypoglycemia, and there clearly the insulin degludec did better than the U100 glargine. And so also, as far as severe hypoglycemia was concerned, so you get a 40% lower rate of severe hypoglycemia, a 53% lower rate of nocturnal severe hypoglycemia. It was confirmed at similar levels of A1C, but in fact, degludec gave a lower fasting plasma glucose compared to the insulin glargine U100. Remember, these trials did not primarily set out to investigate hypoglycemia, and in fact, in the inclusion criteria, they excluded patients who were at a high risk of hypoglycemia. So these are patients who are otherwise at a high CV risk, but really not at a very high severe risk for hypoglycemia, except if they had a renal condition. Now, this is one trial which really was looking into hypoglycemia per se. This is the switch 2 trial, where you're now looking at degludec versus U100 glargine, okay? And you have a sort of a switch over period. You have an initial period of a titration period of 16 weeks, followed by a 16-week maintenance period on one particular insulin. It could be degludec or glargine. And after these 32 weeks, those who were on U100 glargine were crossed over to degludec for a further similar period of 16 weeks titration and 16 weeks maintenance. Those initially on degludec were switched over to glargine. And within each group, there was also this AM-PM randomization on a 1:1 basis. So these were patients who were at least 18 years of age, who had diabetes for at least 26 weeks. They had basal insulin with or without oral anti-diabetic agents. Their A1C was less than 9.5. And this is important. They had at least one hypoglycemia risk factor. So what does that mean? It means you should have had at least one severe hypoglycemia in the past 1 year, or you should have had a hypoglycemic episode within the last 12 weeks, or you should have had hypoglycemia unawareness, or you should have been exposed to insulin for at least 5 years, or you should have had moderate renal failure, which translates to an eGFR of 30 to 59, okay? So if you met one of those criteria, you're defined as having a hypoglycemia risk. So in fact, these patients were included in this particular trial, and this I told you, they were randomized 1:1, but even within that, they were randomized 1:1 for AM and PM. And if there was a prior insulin regimen of twice-a-day insulin, then they made a 20% reduction in the total insulin dose. Now, it's like you're titrating the insulin based on the fasting, and the A1C, which was not, of course, the primary thing they were looking for, but it was really the same between the two groups of insulins. But what was the primary endpoint was the overall symptomatic hypoglycemia, which means either a severe hypoglycemia, that's a blood glucose, which is a hypoglycemia event that requires a third-party assistance, or it could be a confirmed hypoglycemia with symptoms plus a blood glucose on the meter showing at least a value of 54 or below. So for overall symptomatic hypoglycemia, there was a 30% lower rate with degludec compared to glargine. Remember, these patients are at a high risk of hypoglycemia. And for the other endpoints, the severe hypoglycemia, it was not numerically significant. It was not significant statistically, though numerically insulin degludec did better. And then nocturnal symptomatic hypoglycemia, there was a statistical benefit with degludec compared to U100 glargine. Okay, so this is how the switch 2 trial panned out. Now, what happens when you compare U300 glargine versus U200 degludec? Mind you, we do not get U200 degludec in our country. But pharmacokinetics of U200 degludec and U100 degludec is just the same, okay? It's not like the glargine thing, okay? So it's as if you're checking U100 versus U300 glargine. It's one and the same. Now, remember, this trial also specifically designed to look into hypoglycemia. You're specifically enrolling patients who have a hypoglycemia risk factor, and these are patients who are at least 18 years of age, who have an A1C of less than 9.5, and a BMI of less than 45, and 1,600 odd of them randomized to either degludec U200 versus glargine 300 plus or without oral agents, but sulfonylureas were excluded, okay? So sulfonylureas were stopped, they were excluded. Now, initially, this trial was meant to go on for 52 weeks, but in the month of February 2018, they found that there was some problem in the reporting of glycemic endpoints and hypoglycemia, and so there was an amendment to preserve the integrity of the trial, and that is why finally the trial ended up with a total treatment period of 88 weeks, okay, which is a pretty long time. So here they are looking specifically at hypoglycemia. The primary endpoint is this: overall symptomatic hypoglycemia in the maintenance period. You have a titration period and then you have a maintenance period, okay? So titration period where insulin is titrated on a weekly basis based on the average of 3 fastings. That is how you do it. That's the titration, but you're not interested in that in the primary endpoint. It's the maintenance period, the overall symptomatic, and then you have various pre-specified secondary endpoints. Now, if you look at the primary endpoint, it doesn't meet statistical significance. You'll say that statistically, there's little difference between, there's no difference statistically between degludec and U300, though it tends to favor degludec. Okay? But once you don't meet the primary endpoint, then the pre-specified secondary endpoints become exploratory endpoints. But for all these other exploratory endpoints in the maintenance period, whether it's nocturnal symptomatic or severe, or if you consider the entire treatment period, whether it's overall symptomatic, nocturnal symptomatic, or severe, degludec did better than, statistically better than U300 insulin. This was a post-hoc analysis. That's the proportion of patients who get hypoglycemia. Again, you have these three categories in the maintenance period and the total treatment period. And again, you find that insulin degludec does better on all these fronts compared to U300 glargine. So significantly lesser proportion of patients would experience hypoglycemia in both the maintenance and total treatment periods compared to U300 glargine. Again, a post-hoc analysis, the hypoglycemia endpoint, the rate of hypoglycemia and the proportion of patients, which I already mentioned. Again, the severe hypoglycemia, it seems to favor degludec, and the rate of hypoglycemia again favors degludec, though it attains significance only for this particular endpoint. So 37% lower overall hypoglycemia in the titration phase with IDEC compared to the IGLAR. So if you just summarize this data now and you compare the study degludec and look at the RCTs and look at the real world data. In fact, in several trials you find that degludec attains a lower A1C. Even in the CONCLUDE trial, there was a difference in the A1C of 0.1%, which was statistically significant. You can see that in the CONCLUDE trial, the A1C was better compared to U300. Otherwise, you get either a similar A1C, but you'd certainly very often get a better fasting reduction with U300 insulin, and you get a lesser, you do that with a lesser dose, okay? So in the CONCLUDE trial, they required 66 units in the degludec arm, 73 units in the U300 arm. So there's a significant reduction in the insulin dose very often, and hypoglycemia throughout you can see, whether it's real world data or whether it's randomized controlled trial, degludec does better than U100 definitely, and even compared to U300, it seems to be doing better. So just my last slide.
The time is up.
Yeah, my last slide. You have three, U100 glargine, U300 glargine, and IDEC. Forget the method of protraction, but the glycemic variability, U300 better than U100, but the inter-day variability slightly higher with U300 compared to IDEC. The glycemic control is really comparable. I told you these insulins, glycemic-wise, control-wise, they are the same. Flexibility, you have a 3-hour flexibility for U300, but you have 8 to 40 hours flexibility with IDEC. And the dose requirement, finally, I told you, compared to U100, the IDEC dose would be expectedly 10 to 12% lower, and with U300 glargine, in fact, the dose would be as low as 20%. So I'll conclude my talk here, and thank you for your patient hearing. It was a pleasure speaking with you. Thank you.
Thank you, Dr. Godbole, for a very detailed analysis of various studies pertaining to hypoglycemia incidence with various newer insulin preparations. Now we'll call our next speaker.